going on today, guys? Today we're going to be talking about ketamine. If you didn't realize that from the over-enthusiastic shouting of ketamine. Ketamine's a fantastic drug. It was discovered in 1956 by scientists over at the Parke-Davis Company. It's an NMDA modulator. It's fantastic. It has 1,000,001 different uses. It does get underused frequently. In some places it is maybe a little bit overused, where they're having like ketamine infusion clinics, which is kind of crazy. But if it works, it works. If there's science that says that it works, it works. So we're not worried about any of that stuff until data prove otherwise. Ketamine's great because we can use it for pain relief, we can use it for induction, and we can also use it for dissociation if we have to in any kind of psychiatric emergency or psychiatric crisis. A lot of the cool things about it is, number one, against most people's assumption, it absolutely 100% unequivocally does not increase intracranial pressure, which means that we can most definitely use it in the presence of trauma if we have to, which is incredibly useful. There is a little bit of evidence that supports that it may induce sometimes retrograde amnesia. It also does induce amnesia in any kind of dissociative dose or higher. There is also statistically insignificant occurrence of reducing blood pressure and or respiratory and ventilatory function. As far as our doses go, and I'll explain these later, for induction we're looking at between 1 and 4.5 milligrams per kilogram, and that would be IV push for adults, and then between 1 and 2 milligrams per kilogram for pediatric patients that are age 3 months and older. We don't want to give it to kids that are under 3 months. For a dissociative dose, according to the American College of Emergency Physicians and the study that they had recently put out, they recommend dosing between 0.4 and 0.6 milligrams, and that would be IV push as well. It was suggested in 2015 from a study that was done by Montov, I believe it was 2015, that the analgesic dose should be 0.3 milligrams per kilogram, and that it should be performed by a IV drip in 100 milliliters of normal saline over the course of 15 minutes or so. Some contraindications that we have are any kind of conditions that are worsened by hypertension, because ketamine does increase blood pressure sometimes, and then any kind of conditions that are going to be aggravated by an increase in intraocular pressure, because there is evidence that it does increase intraocular pressure as well. Any kind of penetrating eye injury, because that increased intraocular pressure is going to cause leakage of the internal contents of the eye. And then any kind of psychiatric disorder where we believe that there might be an amplification of psychiatric side effects of ketamine, mostly of which being emergence phenomenon. For anybody that's not aware of what emergence phenomenon is, whenever your conscious and subconscious brain are disconnected pharmacologically and the medication starts to wear off and those two pieces of the brain merge, what can happen is people's brains are catching up, so to speak, to what is going on versus what happened, and they're trying to fill in the blanks, so it can cause hysteria or panic. People can become violent during that, but that's easily combated with ketamine by giving relatively low doses of Versed. 1-2 milligrams, right around there, and that can help out a lot. It'll bring them back into a more sedated state, but it'll also give their brain time to reconnect and reestablish with what's going on, and you can kind of talk them through it while it's going on. Say, hey, it's okay, we gave you this medication, this is why, relax, you'll feel better soon, and just kind of let them ride it out, and they'll be okay eventually. So going into the Montov study, there's a randomized double dummy study including 48 patients with a pain score greater than 5 that were presented to the emergency room. They were randomly given ketamine in 2 different forms. One, they were given an IV push over the course of 5 minutes, or they were given an IV drip over the course of 15 minutes, same dosing applied. In the study group that had the infusion, over 15 minutes, they had reduced rates of feeling of unreality, sedation, and no difference in analgesic efficacy. And they also had a decrease in other side effects such as hallucinations, dizziness, mood change, and discomfort, which is really good because basically the study is saying, hey, we gave it to 48 patients that came to the emergency room that were in a relatively significant amount of pain. We gave them a very low dose of ketamine, and it had little to no adverse effects. And oh, by the way, it worked just as well as narcotic pain medication would have, which is fantastic. Obviously, with the national opioid epidemic that's going on right now, we want to avoid giving people opiates if they don't absolutely need them. I'm not saying don't give pain medication, because obviously if we have to give pain medication, we'll give pain medication. That's not a big deal. But unnecessarily, we don't really want to be looking at that. So we're looking at moving on down to excited delirium now. Suggested dose, this is by Shepke, et al. In 2014. They were recommending a dose of 4.0 milligrams per kilogram intramuscular. They had a sample of 50 patients. They reached peak sedation in less than 5 minutes. The average time was within 2 minutes. And in only 3 of those cases, there was no respiratory depression. But it's also worth noting that in those 3 cases, Versed was also given, and I believe only one of the patients was hypoxic, which is good. It could have been any kind of comorbidity, whether it be something that the paramedics did with giving them Versed as well, or any kind of substances that they may have been on as well. And that's kind of a common factor during these studies, is you'll see a small group of outliers where they don't follow the trends of everybody else, and you have to look deeper into it and figure out why exactly they were outliers. And in many of the cases, you'll notice that they were outliers because they were either on some other medication, they had to be given some other medication besides the ketamine, or there were other comorbid factors that were outside of anybody's control. Moving on down, one thing that you'll see talking about side effects and stuff like that, there are higher rates of intubation upon arrival to the emergency department. A lot of this, it seems in the studies, from what I was reading anyways, it seems that a lot of it is provider discomfort with having a patient that they know is pharmacologically sedated and not doing anything to support them from a ventilatory point of view. And this is supported by the studies that were performed by Burnett in 2015 as well as Olives in 2016. Both of those state, like I said, there's higher rates of intubation in the emergency department, and it appeared that it was associated with provider comfort in managing patients sedated with ketamine. Only 16 out of 16 of those patients, only one was hypoxic. That was one that I was mentioning before. Going to the Olive study in 2016, they showed that when a ketamine patient presented to the emergency room, 85 out of the 135 were intubated, and 76% of those were performed by 2 physicians. So the same 2 physicians that received those patients intubated all of those people, and this was over the course of, I believe, 2 years or so, was how long the cohort lasted. And only 3% of those patients, or 4 patients total, were intubated in the field. 2 of these people ended up dying, but their official cause of death was ruled as amphetamine citralopam overdose. And then there's another one where they had a subtherapeutic level of a seizure medication. Of all the patients that were intubated in the emergency room, it was because of not able to protect airway and not otherwise specific. So it's really just a way of saying we're doing this out of caution, which really doesn't make sense. If I don't have to shove a tube down somebody's throat, I don't want to. Something that is kind of interesting about that study is they went as far as to draw pH, ethanol, and lactate levels, and the pH and ethanol levels of the intubated patients in the emergency room were comparable to the non-intubated patients, which means that their respiratory status was relatively equivalent. The only difference was the lactate. The intubated group was the non-intubated group was slightly higher at 7.05 versus 5.6, which is relatively insignificant as far as differences go. A lot of this, I think, can be explained by dogma, unfortunately, of, two physicians that believe, oh, if there's a GCS less than 8, you need to intubate. Well, okay, we get alcoholics all the time who are drunk, and we let them do what? Sleep it off. Even though their GCS is less than 8, we don't go shoving breathing tubes down their throat because they're drunk. If we gave them ketamine and they're sleeping and they're breathing fine and their SATs are fine, okay, well, don't worry about it because we did that to them. It's pretty much the same as them being drunk. Hey, I'm trying to shoot a video here. And in nearly all of the studies, unexpected or adverse reactions were nearly non-existent, but I think a lot of this can be explained because a lot of the studies came from pre-hospital administration of ketamine, as paramedics were really good at giving it. In studies, when paramedics are involved, there does tend to be a little bit of underreporting that happens, just because of the way that we write our reports, which is fine. It just kind of makes the data quality somewhat questionable, but a lot of these reports also did coincide with what the hospital reports were saying, what the charts were saying. So all in all, they were good data sets that were in there. From a medical control standpoint, I do believe ketamine's a fantastic drug. It's not a silver bullet by any means, but it is pretty great because when you look at it from a cost perspective, it can cost anywhere between 35 cents a vial all the way up to $14 a vial. But when you look at what you're getting for the money, from, let's say, you order from BMP or something and they have it marked up to $135 a bottle, okay, that's cool, because we're replacing 3 different medications with one medication. We shouldn't have to carry X, Y, and Z medication anymore just to be let off to expire. When we can get analgesia done, we can induce, and then on top of that we can also give a dissociative dose for psychiatric disorders. For excited delirium, it's a fantastic drug. Like I said, it takes about 2 minutes for it to reach peak, which is fantastic, so we can literally just monkey pile on someone with the cops or what have you, give them an ion injection, wait it out a little bit. As soon as they start calming down, get off of them, roll them on their back, support them in any way that they need to, get them in the ambulance and go to the hospital, and they'll behave for at least the next hour or so for the hospital, and then they can decide what to do from there, which is fantastic. As far as pain management goes, especially for pediatric patients, it's fantastic because we have the added benefit of amnesia, which can most certainly be induced sometimes. So not only are we helping with them with their pain, but they might have a more hazy recollection of it. And on top of that, we don't have to worry about the induction of bradycardia or hypotension, so we don't have to calculate doses for atropine and all that good stuff should it be needed. So ultimately, like I said before in the very beginning of this, ketamine's fantastic, it's great, and that's all the information you need to know. Feel free to like, comment, subscribe if you enjoyed the video. As always, let me know if you have any recommendations for things that you want to learn about. Start a discussion in the comment section. I'll be more than happy to have a healthy discussion with anybody. And then I'll also be working on providing all the links for the studies that I do represent in these videos. As always, thanks for coming by. Be safe and take care.